Vectra DA Patient Cases, presented by Dr. Grace C. Wright, Clinical Associate Professor in the Department of Medicine at NYU Langone Health.
Now, case 3, another fascinating one. This is what happens when you practice in Midtown Manhattan in New York City. Patients are all over the place. Can't stop them, can't keep them in. So this is a 50-year-old Caucasian female. Her BMI is 19. Normal here for me is 18.5, so she's really hanging out on the very, very bottom end of normal. She's 5'6", weight 122, and she again walks in with complaints of what we'd expect, pain, stiffness in her shoulders, wrists, and hands. But her problem is she was this very svelte, chic, sophisticated Manhattanite. Nobody believed her. Her fingers were spidery, so they said, "You're not really swollen. Look at your fingers. You're still skinny." She goes, "These are not my hands. I can't move them. I'm really stiff." She was actually a television producer, could really not perform well with any of her tasks. And she'd actually seen a rheumatologist who said, "You're not tender. You have fibromyalgia. I don't really think you're swollen." So she eventually comes to me because she can't do her video productions. And when I see her, she's this thin, spidery-fingered woman, but she's got subtle swelling everywhere. And here's a point that I sort of want to emphasize. Subtle swelling is still swelling. When you count a swollen, it's either swollen or not. It's a binary decision, right? We don't actually quantify the extent of swelling when we're doing a swollen joint count. Once you pass that threshold, you are that. So if I miss that subtle swelling in this patient, I count her as 0 swollen, 0 tender, with an overlay of fibromyalgia. So she actually was tender in shoulders, elbows, wrists, small joints of the hands. She had no erosions on x-rays. She has no family history contributing to this. But guess what? She's double seropositive. And they were relatively impressive. They were at the upper limit or above the upper limit of normal in my lab. And her C-reactive protein was elevated. So she comes to me on NSAIDs. We get her on methotrexate, escalate that up. She is beyond needlephobic. Just checking her labs for methotrexate toxicity, I have to sing happy birthday every time. Thank God I can sing happy birthday every time. So she wants to avoid injections or infusions. She travels a lot still all over the world and is very concerned about storage of drugs during this. So this was her story. She comes in at the bottom end of the spectrum. She still has an elevated C-reactive protein. She walks in really, this was before I saw her, still comes in now with a high C-di. Here's her unadjusted, which was still high, it was 55. But when we adjust based on her age, gender, and leptin scores, she jumps up 10 points. So she goes from the low high to towards a higher spectrum of high. And as we treat her, her age doesn't change, but we see that the pressure, so she actually had more inflammatory burden than she appeared to have because she looked so, thin and healthy that we underestimated the extent of her disease. So there's 2 ways that we have implicit bias or explicit bias that we generate with our patients, whether or not we sort of assume that they're not as sick as they are because they have a certain look, or we simply miss it because we're looking for something and we can't see it. It's being masked by all of these other factors. So she actually has done quite well in shifting her score from 65 to 42, a 20-point drop. So her delta here is pretty impressive, and doing that only on oral methotrexate, which I'm very thankful that worked for her because she was not yet willing to make the leap. And what is the take-home point? Adiposity contributes to the inflammatory burden. It can contribute in ways that we underestimate or overestimate. Patients at the high and low ends of the spectrum may have inaccurate assessments because we were making these assumptions of the surrogacy of adiposity and the inflammatory burden that goes with it. And now that we have the ability to measure, why guess when you can check, right? We now have the capacity to sort of dive deeper and look at the use of biomarkers to assess this. So these adjustments take into account the variables of age, gender, and adiposity, as Len has so very nicely pointed out. We have another way to look at this, another way to cut through another layer of bias as we look at our patients and understand that, yes, they are heterogeneous, their disease is heterogeneous, we're heterogeneous, but we think that a single marker always does it. Doesn't make sense to me, right? So the way that we cut through heterogeneity is to have composite things that look at the differences amongst us. So I thank you for your attention, and I wish you excitement as you go on the journey of understanding adjustments and how we see through all of the different ways in which we look at the inflammatory burden.